Hi everyone, you're most welcome to our session today. This is our second conference, the IUSSP Scientific Panel on Population, Poverty and Inequality. And we are in the session that is called Adult Health. We'll have presentations, 4 presentations on different topics about adult health. And for now, we have the four presenters, but we will play pre-recorded sessions. This was done to help just in case there's internet connectivity issues so that we still can go ahead with their presentations. But in the same season as we watch the presentations, they'll be backstage just watching and checking out any of the questions that you could have or the comments, which you can post in the Q&A. We have a chat room, but I would request that we post our questions in the Q&A so that they can be easily accessed. And in the Q&A, when you post a question, just in case someone else would like to vote it up, they can vote it up so that it shows it's a top priority if they also wanted to ask a similar question or they like it, and then it will be addressed. In this session, we also have Mari. Mari is going to be the moderator for the Q&A sessions, the Q&A part of the presentation, so you can direct your questions there. Welcome, Jill, and your presentation will be the first to go live. Please play Jill's presentation. Most welcome.
This is joint work with Gunther Fink and Ishani Kanpal. It has been recorded in developing countries that the progress on health service coverage has been considerably more pro-poor than progress on health status. This could be explained by the fact that the poor might not get the same quality of care, or maybe the services might not correspond as well to the needs of the poor. In this paper, we focus on the first hypothesis and study the relationship between wealth and quality of antenatal consultations in DRC. We decompose the wealth quality gradients into different sources of inequality and assess the relationship between price, quality of care, and wealth. We considered 3 broad sources of inequality in quality of care. The first one is sorting into markets by socioeconomic status. What we mean by that is maybe wealthy women simply live in areas where there are better health facilities, so women face different choice sets. This could arise from unequal allocation or availability of resources in different areas, or by difficulty to recruit and retain providers in remote areas. The second source is within market differential sorting into facilities, meaning that maybe the wealthy and the poor face the same choice sets when deciding whether and where to receive care, but they make different choices based on differences in budget constraints, preferences, or maybe even health-related knowledge. Lastly, the last source is within facility differential quality, meaning that wealthy and poor might attend the same facilities but receive different quality of care. The Democratic Republic of Congo, unfortunately, is a good context to study this issue because there is a weak link between health service utilization and health outcomes. Although more than 80% of women receive antenatal care and delivery in health facilities, mortality rates remain among the highest in the world. There is a steep socioeconomic gradient in health outcomes, and the gaps in utilization between the poor and the rich are smaller than in magnitude relative to the gaps in health outcomes. Another important aspect of this context is that facilities, whether they're public, private, or non-for-profit, typically rely on user fees for curative and preventive care. The data was collected as part of a baseline survey for evaluation of a large health financing project financed by the World Bank in 2015 and 16. We covered 133 health zones or sub-provinces, which represent 26% of the health zones in the country. In each health zone, we randomly selected 5 catchment areas, and in each catchment area, we had a sample of about 50 households where we had interviews with recently pregnant women, and we conducted health center assessments where we conducted direct observations of antenatal consultations as well as exit interviews with the pregnant women. The household survey provides us with a large sample of recently pregnant women. However, we are wary of recall bias due to the time lag between the antenatal care and the interviews, as well as differential understanding of the clinical content of care. The direct clinical observations provide a more accurate measurement of quality of care. However, we are cognizant that there might be a Hawthorne effect if providers perform better when they know they're being observed. And the exit interviews provide us with out-of-pocket payments information as well as the socioeconomic status of the pregnant women. So we triangulate these three sources of data. We first characterize the overall wealth quality gradient. We define wealth in a standard way by creating indexes with principal component analysis of household assets. And for quality of care, we define different indexes for the three different sources of data based on the share of items completed, and those items are taken from WHO guidelines. Here you can see some examples of the items that are included in the different indexes, such as blood pressure measurements, HIV testing, syphilis testing, iron supplementation, and different sorts of counseling. What I want to highlight is that the content of these three indexes are different. First, the household data represents content of care throughout the pregnancy, while the direct observation and exit indexes represent only content of care in first consultation. So it's important to remember that these indexes are not directly comparable. Here we show the regression, the overall wealth quality gradient. We start with the household data. We find that a 1 standard deviation in household wealth is associated with 3 percentage point increase in protocol compliance, even when we control for women's education and other socio-demographic characteristics. We also find this statistically significant relationship in the direct clinical observation data. We find somewhat smaller coefficient, 1.6 percentage point. However, emphasizing again that the definition of the indexes is a bit different, and we are wary of the Hawthorne effect that this might be an underestimation of the actual relationship because providers know that they're being observed. After we establish that there is a statistically significant relationship between wealth and quality of care, we start decomposing the sources of it. So first we want to know whether this relationship is because wealthier women live in areas with better care. And we find that indeed wealthier women live in catchment areas of health centers that are more likely to be referral health centers. Health centers provide a wider set of services, as well as health centers providing that have better availability of equipment and consumables. So remember, those are health centers officially serving the villages women reside in, the catchment area, although women might choose other health centers. However, even when we include village dummies into our gradient, we still find a statistically significant relationship. So even when comparing women of different socioeconomic status within the same village, we find that the wealthier receive better quality of care. That being said, most of the overall wealth quality gradient is due to this cross-market wealth quality relationship. So the coefficient reduced for 3 percentage points when we do not have the village dummies to 1 percentage point when we do include this dummy. Next, we try to understand what's driving the within village wealth quality relationship. So do women of different socioeconomic background attend different facilities? And we find that indeed that's the case. Wealthier women are significantly more likely to attend higher level facilities. Here in this case, 1 standard deviation in wealth is associated with a 4 percentage point higher likelihood of attending such a facilities, even when we include village fixed effect. And wealthier women are also more likely to bypass the local health facilities and seek care outside of the catchment area, although they're less likely to do so when the local facility has higher availability of equipment and consumables. Some of the different choices made by, or the way the choices are being made by wealthy and poor women might be characterized by this data from the exit interviews. Women above the wealth median are statistically significantly more likely to use some mode of transportation other than walking, even though still it's not very much. It's 12% versus 5% for women below the wealth median. We also asked the women what's the primary reason for receiving antenatal care at that specific facilities, the most common answer for all women was that this is the closest facility. However, women below the wealth median were statistically significantly more likely to say that they chose the facility because of the low price, while women above the wealth median were statistically significantly more likely to say that they chose the facility due to confidence in staff and the quality of services the facility offers. So after we established that women, wealthy and poor, make different choices, we also test whether there is within facility inequality in care. And again, we find when we use the direct clinical observation data, we find that wealth, one standard deviation in wealth, is associated with a 0.6 percentage point increase in protocol compliance, and this relationship is statistically significant. Unfortunately, we are not sure whether this is really representing what this is representing. It could be discrimination. Providers might exert less effort when treating women with lower educational or socioeconomic status than theirs. It could also be that content of care be driven by women to some extent. Maybe wealthier women are more empowered and ask more questions and initiate more discussions, for example, about family planning or nutrition that are included as items in our indexes. It could also be that poor women choose limited packages of care because many facilities charge separately for diagnostic tests, consumables, and consultations. So maybe the women just choose different packages of care even though they choose to receive it in the same health facilities. So our data provides limited insight into that, and we think this merits further investigation. In the last part of the paper, we studied the relationship between price, quality of care, and wealth. Here we regress price of antenatal consultations on the quality index, and this is using the exit interview data. And we find a statistically significant strong relationship between price and clinical content of care, regardless of whether we're adding health zone dummies or facility dummies. As expected, we also find a strong relationship when we look at a relationship between price and wealth. However, we also find that this relationship holds even when we control for the quality index. That meaning that wealthier women receive better quality of care, but even on a given quality of care, they pay more. There are two main reasons why we think this could happen. One is that there is cross-subsidization, meaning that health providers charge more to the wealthy in order to subsidize the care for the poor, or maybe facilities are profit maximizing and they price discriminate for that cause. And in an admittedly hand-wavy way to kind of test this to hypothesis, our intuition is that the price gap should be higher when there are more poor to wealthy women, because we need to recover more money for each wealthy pregnant woman to cover the cost of the poor. And we find the opposite. We find that the price gap increases in the local ratio of wealthy to poor, suggesting that providers do not charge different prices only for redistributive reasons. To conclude, we find robust evidence on the existence of wealth quality gradient in DRC. We find that most of the gradient is explained by spatial correlation between household wealth and quality of care in local facilities, but there is also significant local gradient, even within villages. Wealthier women travel further and pay more to receive better care, but we also find evidence of within facility wealth quality relationship, which merits further research. We find that wealthier women pay more for the same quality of care, even though they receive better quality of care on average. We have some ongoing work to further study this issue. One of them is evaluation of the performance-based financing project in DRC that might address this issue in several ways, such as financial incentives for quality of service, for provision of care to the poorest in the community, as well as higher incentives in more remote areas. We're also estimating a facility choice model to study the trade-offs between distant price and quality of care when women decide where to receive antenatal care. And we're also collecting data on pro-social attitudes of health providers to understand how they do.
Thank you for the opportunity to share our work, Survival Expectations in Human Capital Investment, Experimental Evidence from South Africa. This is joint work with Jeremy Borowski, Dan Flanagan, Mandla Zikale, Frank Tanzer, and Till Berninghausen. Economic theory predicts that human capital investment should increase with life expectancy. Evidence for this link comes from natural experiments, from maternal mortality.
Are we going to discuss Jill's paper?
Jacob, you just wait a minute, and not really a minute, you wait until you present your paper, and then after you've presented your paper, we'll go to Laura. After Laura's paper, we'll go to the paper by Sophia, and after all the presentations, we'll now have the discussions. So we'll first go with the presentations.
Declines in Sri Lanka,
so we can go ahead
HIV
with
mortality
Jacob's
patterns in sub-Saharan Africa, and HIV treatment scale-up. Survival expectations, that is, beliefs about life expectancy, are the presumed mechanism in these studies. But less is known about how people form and update beliefs about their own survival. Do changes in survival expectations themselves lead to increased human capital investment? In this study, we set out to experimentally manipulate survival expectations in the context of very large background increases in population life expectancy. We previously documented that adult life expectancy in rural KwaZulu-Natal increased from 49 years to 67 years of age, an 18-year increase since 2004. This was with the scale-up of HIV treatment in the public sector in South Africa. In this study, we collect data on survival expectations of young adults in this setting. We designed a video intervention to deliver information on these large life expectancy gains, and we conduct a randomized evaluation to assess the impact of this intervention on survival expectations, human capital investment, and HIV testing. Our study contributes to the literature on informational interventions. Informational interventions have been effective in increasing perceived returns to schooling, to starting a business, beliefs about HIV prevalence, and beliefs about occupational mortality risks. In one related study, Chancho, Delavan, Kohler, and Kohler provided adults ages 45 years and older in Malawi with information on 5 and 10-year survival probabilities. Although the information did not increase survival expectations, it did increase investments in agriculture and reduced risky sexual behaviors. To our knowledge, this is the only other study that has provided information on population mortality patterns. We also contribute to the literature on information processing. The literature on optimal expectations suggests that people actually derive utility directly from the beliefs that they hold, and particularly whether those beliefs are optimistic. As a result, people engage in defensive measures, information avoidance, in selective inattention, or biased processing in order to maintain those beliefs. The hedonic costs to thinking about a risk that people don't want to think about may therefore limit the extent to which they update when faced with new information. To preview our results, the video intervention we designed had no effect on average. However, it increased survival expectations and human capital investment amongst people who believed that they were currently HIV infected. Interestingly, amongst people who believed that they were not currently HIV infected, the video actually reduced survival expectations and perceived likelihood of future infection was not related at all to the impact of the intervention. Descriptive results alongside these experimental results suggest that survival expectations may not be clear-eyed expectations per se, and are more consistent with biased information processing for HIV negatives. Our study recruited 427 young adults from their households, ages 18 to 25. The study was nested within the population surveillance of the Africa Health Research Institute. The study consisted of a baseline study visit in which there was a baseline survey, and participants in that context viewed the video intervention or not. They then received several behavioral offers, the opportunity and invitation to participate in a job search skills workshop held in the community in the subsequent weeks, a savings tin where they could allocate some of their participant incentive, and a voucher for free HIV testing, as well as an offer to purchase condoms. We followed up each of these behavioral offers over the subsequent weeks, and at 8 weeks, we returned to their homes to do a follow-up survey to look at survival expectations again. We elicited survival expectations using the methods adapted from Delavand and Kohler in Malawi. Participants were given 20 beans in a tray that is shown here. They were told these 20 beans represent chances that you'll still be alive at different ages. You have 20 beans now because you're definitely alive. Now move the beans, put the beans in kusokwenzeka, which means it will happen. Now move the beans until the number of beans in kusokwenzeka shows the chances that you will still be alive at age X, and the number of beans in ngekakwenzeka, it will not happen, shows the chances that you will not still be alive at age X. Asking about survival expectations in this way enabled us to trace out the full survival curve, perceived survival curve for young adults out to age 80. And integrating underneath this curve, we were able to compute subjective life expectancy for all participants. We also elicited information on beliefs about other relevant constructs. We asked people about the anticipated length of life that they perceived for someone who is HIV negative, for someone who is HIV positive, and for someone who's HIV positive and on ARVs. We also asked people using the beans about the chances that they believe that they were currently HIV infected and about the chances that they believe that they would become HIV infected at some point in their life. The average perceived lifetime chances of HIV infection were 38%, which is pretty close to the population prevalence of HIV amongst adults in this setting. The informational video intervention was developed in collaboration with the local HIV support group, as well as the Africa Health Research Institute's Community Engagement Office. In this intervention, we presented infographics showing the data on the large increases in life expectancy in the region. We also nested this information in the context of narratives of 3 people in this local HIV support group who had been on HIV treatment for over a decade and were investing in the future, starting a farm, for example. In the respondents who saw the video, in their words, it taught me that if you're HIV positive, your life is not over. You can still achieve your dreams. It made me think of the future, that I too have a long way to go. Turning to results, we find that the intervention actually had no effect on average on changes on our primary outcomes, which were changes in subjective life expectancy from baseline to 8 weeks, participation in HIV testing, and an index of future-oriented behaviors. It had no impact either on any of those behaviors individually, nor on measures of future orientation or mental health. However, we found substantial effect heterogeneity by HIV risk. People who perceived low risk of HIV infection saw reductions in subjective life expectancy with the video, whereas those who perceived high risk of HIV infection saw increases in subjective life expectancy. Drilling down further, we saw that these effects were really driven by beliefs about current HIV, that these effects were really driven by beliefs about current HIV status. Conditional on current HIV status, lifetime HIV risk actually had no relationship with the impact of the video. Based on current and lifetime HIV infection risk, we further stratified the sample into 3 groups. A group that believed that their current HIV infection risk was high, a group that believed that they were likely currently not HIV infected, but who perceived a high lifetime risk of HIV infection, and a group who perceived both current and lifetime HIV infection risk to be low. In the first group, those who perceived that they were currently HIV infected, the video intervention increased subjective life expectancy by 7.7 years relative to controls. However, it had negative impacts in the other 2 groups. In the first group, those who perceived that they were currently HIV infected, the intervention substantially increased attendance at the job search skills workshop, which was our primary indicator of human capital investment. Interestingly, it reduced the amount of savings allocated to the savings tin, implying that people given the opportunity to save this participant incentive in their tin opted to keep more in their pocket, were unable to say whether the returns to keeping it in their pocket were higher or lower than putting it in the savings tin. To summarize the experimental results, the video had no effect on average. Amongst people who believed that they were currently HIV positive, it increased survival expectations and human capital investment, as proxied by attendance of this job search skills workshop. Amongst people who believed that they are currently HIV negative, it reduced survival expectations, and perceived future HIV risk did not modify impact, despite many people still perceiving high future risk. The result amongst HIV negatives causes us to ask whether survival expectations are really expectations. In an expected utility model, people would average over potential states of the world, but in the trial, people who believed that they were HIV negative did not update based on information about the HIV positive state of the world. Our results for HIV negatives are more consistent with a model in which hedonic costs to thinking about the HIV positive state lead HIV negatives to selectively ignore that state. We find further support for this biased processing interpretation from two descriptive results. First, when we regress subjective life expectancy on other beliefs, we observe no interaction between the perceived likelihood of future HIV infection and beliefs about life expectancy in the HIV positive state of the world. We would expect this interaction term under if people were taking expectations across these different states of the world. Secondly, when we regress subjective life expectancy on household exposures that we would expect to shape beliefs about the HIV state of the world, we find surprising results. Exposure to an HIV death was associated with increased subjective life expectancy, and exposure to an ART initiator, someone on HIV treatment in the household, actually was associated with lower subjective life expectancy. These wrong direction results make sense if these exposures actually raise or lower the hedonic costs of thinking about the HIV positive state and increase or decrease the likelihood that people ignore that state when forming survival expectations. Biased information processing therefore offers a plausible explanation for our results. We find evidence supporting the Ben-Porath mechanism amongst people who believed that they were HIV positive, but we find no impact of the intervention on aggregate across this population. Information on life expectancy gains due to interventions that affect mortality risk related to specific conditions may have limited impact on survival expectations if people engage in defensive maneuvers such as bias processing that limit updating. I'd like to acknowledge all those involved in the study, and would like to dedicate the presentation paper to Sandra Dlamini, who is one of the members of the HIV support group, and in fact, the founder of the HIV support group that we collaborated with. It was a pleasure to know her and to collaborate with her, and she was quite a force. Thank you very much.
Thank you, Jacob, for your presentation. Would now like to welcome Laura's presentation. Please play Laura's presentation.
My name is Laura Sochas, and I'm going to be telling you today about a paper that I wrote during my PhD, which focuses on describing and sort of introducing a new hypothesis, which I call the concurrent barrier hypothesis. So I'm currently, just to say quickly, a postdoc at the University of Oxford. All right, so my thinking around this issue started from my engagement with sort of classical theories of health inequalities and social epidemiology, especially the inverse equity hypothesis by Victoria and al. And essentially, the inverse equity hypothesis says that healthcare inequalities at a population level can increase as average outcome, health outcome, or healthcare access improves. And that kind of implies that government intervention is necessary in order to achieve a progressive path to universal health coverage. Now, governments, especially in low and middle income countries, have attempted to follow this progressive path to universal health coverage by implementing policies such as policies that remove financial barriers to healthcare access. And there's many examples of those, from abolishing health user fees to distributing cash transfers, etc. But what we see from the literature is that actually in practice, such interventions haven't always been successful. And we've had a lot of mixed results, as you can see here from the slide. Now, some of the explanations that have been put forward for this is partly to do with, different methodologies across different studies, or also the fact that some reforms, some policies have been better implemented than others. But another possible explanation for such mixed results that hasn't yet been formalized or evaluated is that in some circumstances, removing a healthcare access barrier could be most beneficial for those facing fewer or no other barriers. And if the most disadvantaged in a population are the ones who face more barriers, then removing a single barrier to access could actually aggravate population-level inequalities. So I formalized these insights for the first time into what I call the concurrent barrier hypothesis. And the CBH, as I call it, has three main conditions. Firstly, if the worse off face more healthcare access barriers than the better off. And secondly, if the worst off are not the only group to face any barriers. And thirdly, if those who benefit the most from a single access barrier being removed are those who face fewer or no other barriers, then removing one barrier to healthcare access could increase population-level inequalities in healthcare access. Now, unlike previous theories, what I think is important about this is that CBH includes government policy as a possible explanation for health inequalities, and it explains how and why pro-equity policies could have unintended adverse effects. Now, the goal of the paper is really to introduce the hypothesis and conduct preliminary empirical research in order to motivate further research and primary data collection. So I'm well aware that my empirical test of the hypothesis is in many ways not ideal, but I'm trying to show proof of concept. Now, the paper is all about barriers, obviously, so I should tell you a little bit about what I mean by that. I draw on existing theoretical frameworks of relational healthcare accessibility to define 6 access barriers that are most prominent in the literature. And I can't go into detail here, but I want to just briefly say that these barriers are really conceptualized as being modifiable through state action. So it's barriers that I conceptualize as, we can potentially remove them through policy action. Now, very quickly, the empirical case I've selected is around facility birth in Zambia, and I can tell you more about why that's an appropriate case. But one of the reasons is that Zambia has high-quality georeferenced data on both maternal healthcare access and health service infrastructure. So I just want to briefly tell you about these data sets. The first one, the 2010 Service Availability and Readiness Assessment, is a census of all health facilities located in 17 of Zambia's districts. So Zambia has 72 districts in total, so it only covers part of the country, but within those districts, it covers all health facilities. And then I geolink that data set to the Demographic Health Survey, the 2013-14 one, which is at the birth level and covers births that occur 5 years before interview, so between 2008 and 2014. And of course, I only select those sampling clusters, observations from those sampling clusters that are in the same districts as the SARA data set. All right, so it won't have escaped you probably that each of these barriers is a pretty big, massive concept, and it's difficult to measure them with one variable each. So in order to help with the legitimacy of this and sort of draw on the best expertise available, I conducted 12 key informant interviews in Lusaka to inform my variable selection. And I also drew on a Zambian-specific literature review. And so you have the variables here next to the concepts which they measure, and I'm very happy to discuss this more in the Q&A. Okay, so the way I tested conditions 1 and 3 of the hypothesis, 1 and 2 of the hypothesis are fairly straightforward, but I just wanted to briefly go into how I attempt to test or explore anyway, condition 3 of CBH, which is those who benefit the most from a single access barrier being removed are those facing fewer or no other barriers. And the way I operationalize this is essentially through an interaction term between one barrier, a given barrier, and the number of other barriers faced. So I have a different equation, a different model for each of the 6 barriers. I want to briefly explain that the number of other barriers faced differs for each barrier because some barriers cannot be experienced without others. Affordability is the only truly independent barrier. And then I wanted to say, sort of explain what sort of shape are we looking for as a sort of valid test of CBH or as proof or indication, I should say, that this condition 3 of CBH holds. And essentially, we're looking for a funnel where the most open side of the funnel is to the left and the closed side is to the right. And that shape is created by a positive interaction short term. So beta 3 should be positive. I also include controls, including mother's education, mother's age at birth, whether there's more than one woman of reproductive age in the household, whether the mother is married, as well as community norms regarding decision-making on the wives accessing healthcare, and also the mother's professional occupation. So the results. Condition 1 and 3 were tested using histograms or kernel density plots. And I sort of operationalize worse off according to 3 socioeconomic dimensions: education, wealth, and rural-urban residents. So the graphs are essentially histograms showing you the distribution of the number of healthcare access barriers faced across socioeconomic groups. The one on the left is just 2 groups for visual clarity. Gray is the more advantaged socioeconomic group and blue is the less advantaged, whereas the graphs on the right show you the full breakdown of groups. And as you can see, you notice that the better off face, those in gray face fewer healthcare access barriers than the worse off, but they still face some barriers. So the average number of barriers is not 0 amongst the better off groups. And I also conduct a test of stochastic dominance, summers D, in order to confirm these conclusions. All right, so now coming to condition 3, which is really sort of the crux of the concurrent barrier hypothesis. From the graphs, remember that we're looking for this funnel, which is more open on the left and closed on the right. We see strong evidence for the concurrent barrier hypothesis for the geographic barrier, as well as the psychosocial barrier, though it's less clear, and to a certain extent also for the affordability barrier. These conclusions are confirmed when we look at the regression tables. In this case, the number of barriers is operationalized as a continuous variable, but I also have a sensitivity test that I can tell you more about in Q&A, where the number of barriers is an indicator variable. And again, we see support for the concurrent barrier hypothesis for the affordability, psychosocial, and also geographic barriers. Now, I also want to say that CBH could be applicable to domains beyond health, such as education, access to jobs, or voting. And in short, any public good where access is hindered by barriers, where barriers can be alleviated by government action, and where the social distribution of barriers follows the patterns established in conditions 1 and 2 of the concurrent barrier hypothesis. The European social policy literature talks of Matthew effects. So, for example, as applied to active labor market policies or childcare services, in the context where these services are monopolized by the most advantaged. But they don't go into this idea of interaction between barriers being a potential cause for this. CBH could also be relevant when we think about interactions between countrywide programs, and it of course has theoretical relevance as providing a potential mechanism, meso-level mechanism, for macro-level theories such as the inverse equity hypothesis and fundamental causes theory. So very last, I'm not going to have time, unfortunately, to talk to this slide, but I would love to discuss future research plans with you in the Q&A if possible. This, as I said before, this paper is really a proof of concept in order to publish something before applying in a larger grant proposal. So your feedback would be very helpful. Thank you very much.
Thank you so much, Laura, for the wonderful presentation. Now we'll move on to the slides, the presentation by Sophia on effect of trade-induced worker displacement on health and mortality in Mexico. Please play her slides.
Hi, everyone. Thank you for joining my talk on the effects of trade-induced worker displacement on health and mortality in Mexico. Recent research in the US has shown an alarming rise in deaths of despair, which has been linked to a cumulative socioeconomic disadvantage exacerbated by trade-induced job loss. However, there are many reasons why in developing countries, this type of jobs could have different effects. And both in developed and developing countries, we see an increase in lifestyle or chronic diseases such as diabetes and cardiovascular disease that are exploding policy problems. So if you look at a middle-income country like Mexico, you see that over the last several decades, infectious diseases have decreased considerably, and chronic diseases such as diabetes and ischemic heart disease are increasing at alarming rates. They explain about a third of overall mortality together with alcohol-related liver disease. And these are the 3 main causes of mortality in Mexico over this period of time. In particular, diabetes has been covered in the media as the main cause of death for several years now. And so over the same period of time, Mexico experienced several changes in its labor market, mainly an export-led expansion of its manufacturing sector after it joined the General Agreements on Tariffs and Trade in 1986 and the North American Free Trade Agreement in 1984. The huge creation of formal and informal employment in the manufacturing sector, especially in export processing plants called maquiladoras. And so when China enters the World Trade Organization in 2001, Mexico faced 2 types of international competition. One, direct import competition in its domestic market because of the Chinese increase in exports to Mexico, and also, and more importantly, an increase in export competition because Chinese exports to the US increased a lot, and Mexico exports about 85% of its manufacturing exports are to the US. So this was also a very relevant source of international competition. So what I do in this paper is explore the effect of trade-induced negative shock to the manufacturing employment on mortality in Mexico. I exploit cross-municipality variation in trade exposure to international competition after China enters the World Trade Organization in 2001. I focus on three main causes of mortality over this period, which are type 2 diabetes, ischemic heart disease, and alcohol-related liver disease, which explain about a third of all mortality in Mexico in this period. And the idea is to provide some insights into the channels that affect the prevalence of chronic disease, such as the relationship between nutrition and income, access to health care, and how these shocks may affect health behaviors. I use data from the Mexican National Institute of Statistics and Geography, INEGI. I have manufacturing employment data coming from the economic census at municipality and industry level, at mortality rates at municipality level, and I have information at 4-digit industry level coming from trade about trade flows. So starting with the model and levels, I want to see the effect of manufacturing employment rate on the age-adjusted mortality rate in a municipality in a year. However, it could be that more or less exposed municipalities to different types of exposure international competition could differ in level and in trends before this shock, so the direct comparison between these municipalities would be biased. So the first step I take is take first differences to address exactly pre-existing differences and to be able to explore within municipality variation in mortality. However, changes in local manufacturing employment could be driven by changes in labor supply rather than labor demand, and so this would also provide estimates that could be biased. In order to address this potential identification threat, I exploit China's entry to the World Trade Organization as a source of variation in local manufacturing labor demand that is uncorrelated with labor supply. And I instrument the change in manufacturing employment, constructing a measure of exposure to both import competition in Mexico's domestic market and export competition in the US market. I follow the seminal paper by Odor, Dorn, and Hanson from 2013, and a paper by Dell, Feigenberg, and Toshima from 2019 in Mexico. And I construct a measure of municipality level exposure to trade shown in equation 4. And so the difference in international competition per worker across municipalities stems from the variation in local industry employment, or the local industry employment structure at the beginning of the period. The beginning of the period will always be 1998, which is the last year before China's entry to the World Trade Organization in 2001. And so the international competition per worker is the weighted average of the changes in Chinese exports to destination D per worker across all industries, where each industry's weight is equal to the labor share in municipality I, and that's what equation 4 is showing you there. And then the change in exports to a destination is the changes in total value of manufacturing exports from China to destination D between 2 years. So the periods I will be looking at are between 1998 and 2003, so a 5-year period, and 1998 to 2013, a 15-year period. And so I can have a first stage that uses either source or either instrument shown by international competition per worker, or I could use both instruments in the same first stage. And that's what the results I'll show you in this presentation. However, the paper has all the destinations, different types of destinations. And so my first stage will be given by equation 6. And I can show you the results right now. So you'll see that there's a strong first stage, a strong negative effect of exposure to international competitions from both sources on the manufacturing employment rate over this period, over both periods of time. And so the second stage results will be the instrumented change in the manufacturing employment rate on mortality. And so you'll see, or we see in this figure that one standard deviation decrease in the manufacturing employment rate increased type 2 diabetes mortality by 2.5 per 100,000 people, which represents about a 13% increase with respect to the baseline mortality rate in 1988. However, we see decreases in ischemic heart disease and alcohol-related liver disease. These are more unprecisely estimated, and they represent a decrease of about 4 to 6%. And so if we see these by gender, we also see that type 2 diabetes is present in men of both periods of times, and the magnitude is similar, however a little smaller just for men. The decreases in ischemic heart disease and alcohol-related liver disease are mainly explained by men. If you see the results for women, we see that there are no effects in terms of magnitude or statistical significance in ischemic heart disease and alcohol-related liver disease. And the magnitude in type 2 diabetes is a bit larger just for women. And so in the second part of the paper, and I won't go into too much detail because of time, but you can see it in the paper, or what we can discuss it later. In the second part of the paper, I try to provide additional supporting evidence on income being one of the main or the main channel that explains this increase in type 2 diabetes over this period of time, mainly contributing to providing evidence about the relationship between income and nutrition and how these households may not be able to access nutritious food after the negative income shock and the negative effect on employment opportunities. So I show in the second part of the paper decreases in wages in the manufacturing sector and on the overall economy. I showed decreases in the share of workers that are formally employed. So informal employment accounts for about 60% of the economy in Mexico. So it's a very relevant problem to look at. And also connected to the decrease in the rate of formal employment is the access to health insurance through employment. So I also see decreases in the share of population that is covered by health insurance. And finally, I look at a survey that has measures related to health outcomes. I see increases in obesity rates, and I see decreases in physical activity, which are mainly risk factors of type 2 diabetes. I see some evidence of decreases in the consumption of alcohol and tobacco, which could be related to the decrease in these types of mortality, although this is just suggestive evidence. And so just to give you the main takeaway of the paper, I identify the impact of trade liberalization on chronic disease mortality through income effects. I find that the increase in type 2 diabetes mortality of about 13% with respect to the baseline may be associated with increase in obesity rates and decreases in income, decreases of access to nutritious food. And well, I guess that's all the time I had, but we can keep on discussing this.
Thank you so much, Sophia, for the wonderful presentation, very insightful and touching on a broad number of health issues. And in the interest of time, I would like to welcome the presenters to give very brief comments about just under 2 minutes. We have very little time left, under 2 minutes to give brief comments on each other's papers. We'll start with you, Sophia. Please give a brief comment on Gill's paper, and then we'll follow through with Gill giving a brief comment on Jacob's paper, and then Jacob gives on Laura's and Laura's. So let's just take about less than 2 minutes each. And please do not forget, for the participants on the session, please do not forget to post your comments, your reactions, your questions in the Q&A. Thank you very much. You're welcome, Sophia.
Sure, thank you. So this was a very interesting paper to read. So the paper documents a positive relationship between wealth and quality of antenatal care in DRC. It explores three sources of inequality in the access to effective healthcare, where the place of residence or the village of residence, within village sorting into different facilities, and also within facilities inequality. What I like the most about the paper is that it provides complementary evidence from the patient side and from the health center side, and the authors achieve this by combining three sources of data: patient exit interviews, clinical observations, and household interviews. And so I have like three main suggestions in the form of questions, really, in case they are useful. The first one is if there is any data on maternal or neonatal mortality coming from these facilities or at the village level of this study that could, I think it would be interesting to see if the quality differences seen match some mortality trends. Second, in the background section, you mentioned that only 17% of women start receiving antenatal care in the first trimester. And I was wondering if this is related to the fact that women don't know the status of the pregnancy early enough. And I was wondering if there is a relationship between this knowledge of when the pregnancy starts and wealth, where, for example, wealthier women know earlier or later, and that could affect when they first access antenatal care. And then whether the protocol compliance could vary depending the time of the trimester when these women have their actual first visit, which is what you mentioned, two of the sources of data. And third and last, some ideas to further explore the within facility wealth quality relationship. I was wondering how many healthcare workers are within each center, and if you could have some fixed effect by healthcare worker that could explain this within facility inequality that you find, and whether there is any type of sorting of providers into patients because of different types of experience may charge more money to and have some relationship with the difference in prices that you find. And finally, if there's any difference of depending on the time of day that these people go to the doctor and whether they visit alone or with children or with spouses, that could change the type of questions that they're asked or the time they spend there. But yeah, it's a super interesting paper, and I was glad to be able to read it in detail. Thanks.
Thank you, Sophia. Please, Gil, go ahead.
Thank you very much, Sophia.
Gil,
I appreciate it.
You're most welcome.
Can you hear? Okay, thank you very much for the comments and your feedback on the paper. Let me jump directly because we don't have enough time. So regarding mortality, we do not have enough power to do with our household survey to look at the effects on mortality. We actually do have another paper where we combine data from similar surveys from several countries, and we do find relationship between quality of care for child curative care and mortality at the catchment area level. We haven't tried it with this, but I think the overall data on mortality, if you look like at DHS, really suggests that it's not just explained by utilization. And we do show that you cannot just look at coverage, but you really need to look at effective coverage and the quality of care. Regarding the timing of initiation, this is an issue that's a problem in many settings in sub-Saharan Africa. And I actually worked on a couple other projects in other countries trying to get women to initiate care earlier. We haven't looked at whether the timing of the first antenatal care is affecting that. But that's part of the reason why we focus only on the first consultation when we do this comparison. I mean, for the household survey, we look at the content of care throughout the pregnancy, but this is something we haven't really looked in very much detail. So, but it could be that, but I would expect the opposite. I would expect women who arrive late to receive more of the content of care rather than women who are wealthier are more likely to initiate on time. So I'm not sure it will go in the right way. Regarding the within facilities, so the way the survey was conducted, we only visited the facility for 1 day. And usually there is a set time for antenatal care, and it's the same midwives or providers that give in the same day. So we didn't have enough variation within facilities of providers. We are in the next survey, we're planning to spend up to 4 days in each facilities, and we might try to do it, but we couldn't do it with the current data. But thanks very much. And I don't think I didn't see any other question, Esther, on the board, right?
So thank you very much for responding to the questions that Sophia raised. Because of our time, it's really limited. We have about 12 more minutes to go. So I would like to request you, Gil, to discuss the paper of Jacob, and then just within under 2 minutes, we'll spill the discussion into the Meet the Authors session. I hope you all have the link to meet the authors in case we are not able to address everything in this session. So you're most welcome.
Thanks. So I really liked, can you hear me? Sorry.
Yes.
Yeah, okay. So this is a topic actually I used to work on decision-making in the context of uncertainty about HIV. And I find it's nice to see a new angle. And as Jacob mentioned, there are many studies now that looked at different sources of uncertainty, whether it's about own infection, whether about transmission rates, whether about how ARTs might affect transmission rates. And I think a lot of the studies, either whether they model explicitly or implicitly, they kind of assume that a lot of the channel will go through the life expectancy. And this paper really targets in the life expectancy angle. Jacob, I think what I would have, and to be fair, the paper is still being drafted, I understand, because you sent an early version, so maybe what I'm saying is a bit trivial. But what I think I would like to really understand is what really shifted with this information, because you work in a setting with very high prevalence and very high existence of ARTs now for many years, and you show that they already had a very big impact at the population level. So I would have liked to really better understand what really were the perceptions before, because you showed actually that people had the right general ideas about that with ARTs, your life expectancy is much larger. So I think it would be important to show who had the wrong and right perceptions and whose perception changed. So maybe it's not about looking at people who are HIV positive, but looking at people who had the wrong perceptions versus people who already knew it. So I think that's something that I would have liked to see and could help maybe interpreting. And then for your interpretation of the bias processing. So again, you show us that HIV negatives didn't update their beliefs about life expectancies with antiretroviral therapy. So then why would they update their beliefs about life expectancies? And what's even more surprising is that they actually revised downward their life expectancy, even though they assign low likelihood to being HIV infected. So it seems quite clear that something changed in the response, but not necessarily through the information the new information that you intended to introduce. So I don't know whether it could be just about the whole exercise about thinking about life expectancies or whether the video, but yeah, I would have liked to kind of to hear more about that. And I'm happy to discuss more, Jacob, but I don't have time right now.
Thank you. Thank you, Gil. Thank you, Gil. Now for Laura and Jacob, you just have about 2 minutes each to give a comment about each other's papers, and then we'll move on to Mari. Please welcome Jacob. You go first.
Thanks so much, Jill, and maybe we can follow up afterwards. Laura, I really enjoyed this paper. I think the central question is, why do government interventions to improve equity so often reduce equity? And it's an important question. It's a compelling sort of high-level theory that is presented in this paper, and sort of nicely mapped to a regression equation that you could imagine being estimated across a whole range of settings. three quick comments. So the first is there's a whole bunch of related literature that this kind of conjured in my mind. So Michael Kramer's sort of O-ring theory about development inputs and how complementarities between different inputs, if you don't address all of them, then you don't get development. That this sort of thing, or the bee sting theory, where people facing multiple barriers, have low incentives to address any, whereas if it's the last one, then there's a huge incentive to address it. And it's sort of these kind of increasing returns for as a result of interventions that's kind of reduce pain. Or from Epi, Ken Rothman's pies, and thinking about necessary versus sufficient conditions for intervention impact. So those are some strands in in related literature. I don't think any of these is exactly what you're talking about, but just kind of to figure out like how yours speaks to that literature. I think in terms of there's some interesting policy implications. So certainly one is multi-level, multimodal interventions that address multiple things at once might be more effective. So you could test that. Challenging, but you could test it. Another is that addressing sort of the fundamental causes, thinking about fundamental causes, addressing the underlying gradient. If there are fundamental causes that address the barriers to all these things, then that could be effective. I think the third, and where I'd sort of suggest kind of pushing this, is asking, are there specific, what are the characteristics of an individual intervention that would make it still equity enhancing given your framework? So, are there sort of sufficient equity enhancing interventions? What would the characteristics be? Like I can imagine a door-to-door immunization campaign where there's just not a lot of other moving parts for individual level differences, the kinds that Jill sort of mentioned it in his work to come up. And I think that drives to kind of my last point, which is, can you be more precise about condition 3? So the way condition 3 is phrased right now is that if those who benefit most from a single access barrier being removed are the same people as those facing fewer or no other barriers. But this sounded more like a result than it did an assumption. It sounded like the thing that you're actually showing rather than the thing that would give rise to that. And so I just kind of wanted to sort of push on that a little bit. I spent a bunch of time kind of sort of trying to grapple with this, but it seems like conditions 1 and 2 are basically universal, right? That there are these gradients in terms of barriers, but that people who are better off still face some barriers. So if that's universal, what is it about specific policies that would make them equity enhancing versus equity reducing? What is that characteristic? And I think that's going to come out in condition 3, but it wasn't clear that it was, for me, my reading wasn't quite precise enough to necessarily tell me when that was going to happen. So those are my.
Thank you so much, Jacob. I think we'll take up the discussion in the meet the authors session, where we'll have a bit of ample time to carry on the discussion. Laura, you're welcome. In just about 2 minutes, try to sum up a comment or two about Jacob's presentation, and then Mary will just jump in straight once Laura is done. Most welcome, Laura.
Thanks. Yeah, so I'm commenting on Sophia's one.
Oh.
No problem. Just checking I got it right. So just to remind all of you, Sophia looks at the effect of a change in the manufacturing employment rate in Mexico, which is instrumented by exposure to import and export competition. And it looks at the effect of this change in employment on leading causes of mortality in Mexico. And what I really liked in terms of her contributions is that it's really a new way of looking at trade-induced chronic diseases. So going beyond the globalization of unhealthy products, especially food, and looking at economic conditions, including effects on employment. And the other thing I really liked is your conclusion, which I think can be phrased in an even stronger way, because it's a really important result to show that chronic diseases such as diabetes aren't only caused by individually modifiable behaviors such as eating, drinking, smoking, lack of exercise, but also by structural conditions that are amenable to macro level policy change. And I think this is so important for the global health literature because it really shifts the blame and the policy recommendations that are so active at the moment in the chronic disease space. So I really encourage you to send that article to our global health policymakers. In terms of comments and improvements, I have a sort of paper, well, a short document that documents the strengths and possible improvements that I'll just send to you. But the one that I just wanted to focus on for the last 10 seconds is potential concerns around the quality of the cause of death data, and potentially the fact that this quality could be different across different municipalities, and that it could have improved at differential rates across different municipalities, particularly for poor or remote populations, even though the data has improved over time. But the problem with improving cause of death data is you're not for at least footnotes on this in the paper, just showing that, yes, you've thought about this, but you're confident that this data is good enough for these purposes. And yeah, I'd love to keep talking about your paper. I have other thoughts, but thank you so much for sharing it with us.
Yes, Mary, you're most welcome to wrap up for us, please.
Is there not somebody from the attendees that wants to make an input? I'm going to come back into the session just now. Anybody else? Okay, let me just, I'll make some quick comments then. So thank you for a fantastic session, great papers, really. And let me just endorse the comments of one comment each from the discussants as just some validation. I think, Gil, your quality index or something is so important. And so the idea then of really pushing on it and testing it out and trying to see what you can do to validate it as the key thing that you're trying to explain is well worth doing. I thought that the comment, Jacob, about what exactly you were expecting in an environment in which there's a huge rollout of ARVs and quite a lot of counseling and all of that as the context within which the video interventions happen. I thought that was an important point that you might need to consider. I thought, Laura, that Jacob made a fantastic point about the literature related to condition 3 and where it, and whether it's an outcome or whether it's really a condition, and where that becomes important is it's not clear, given that you're dealing with the intersections, if you like. Intersection sounds like interaction, so it's very clever that you're dealing with it with an interaction term. But if there's all sorts of nonlinearities, it's not clear that the interaction term is going to cope with that. And then Sophia, Laura's point about the fact that it's amazing really to see these health outcome results as a response to local economy or structural shocks. But at the end of the day, I guess one would want to understand what's driving that. It would be very good to see some evidence of consumption patterns or just something that it's a stunning result. But if you can sort of ground it in what changes actually happen to make it happen, that would be amazing. But anyway, what a great session. So thank you.
Thank you so much, everyone. Thank you for your time, for your wonderful presentations. I'd like to invite you to continue with the discussion in our Q&A. no, not in our Q&A, in our Meet the Authors. So let's meet there and just keep interacting. Thank you for your wonderful time. Thank you so much. Participants, thank you for your time. Attendees, thank you for your time. And you can also join in the Meet the Authors session and we continue the discussion. Bye for now. See you in a short while.
Thank you, Esther.
Thank you.
Thank you, Ray. Thank you, everyone.
Thank you. See you anon.
Thank you.